Endometrial cancer is a malignancy that develops in the lining of the uterus, called the endometrium. The endometrium plays a crucial role in the menstrual cycle and pregnancy. As one of the most common gynecological cancers, understanding endometrial cancer is vital for early detection, effective treatment, and improved patient outcomes. In this presentation, we'll explore the various aspects of endometrial cancer, from its types and risk factors to current treatments and future research directions. Endometrial cancer arises in the uterine lining and splits into two main categories with unique traits. Type 1 makes up 80 to 90% of cases and is mostly endometrioid adenocarcinoma. It is driven by estrogen, often tied to excess hormonal stimulation, and offers a better prognosis due to slower growth and good response to treatment. Type 2 covers 10 to 20% of cases and includes non-endometrioid carcinomas like serous and clear cell carcinomas. These aggressive tumors grow independently of estrogen, spread early, and carry worse outcomes despite advanced care. Rare subtypes such as carcinosarcomas or undifferentiated carcinomas also exist but appear less often. This framework shapes diagnosis, treatment plans, and predictions in personalized oncology. With these classifications shaping treatment approaches, let's now explore how endometrial cancer impacts women globally through its epidemiology. Endometrial cancer ranks as the sixth most common cancer in women globally, with about 420,000 new cases in 2020. In the United States, it tops the list of gynecologic cancers. It mainly strikes post-menopausal women, averaging 60 years at diagnosis. Racial disparities stand out. White women face higher incidence, yet black women encounter more aggressive disease and greater mortality rates. These trends highlight the need for tailored screening and intervention efforts. These epidemiological insights reveal who's affected, but what drives endometrial cancer's onset leads us to its risk factors. Several risk factors fuel endometrial cancer's development. Prolonged estrogen exposure from hormone therapy or natural causes stands out as a key driver. Obesity boosts risk by ramping up estrogen production in fat tissue. Women never pregnant and those with late menopause face higher odds as well. Tamoxifen, used for breast cancer, oddly raises endometrial risk too. Genetic conditions like Lynch syndrome contribute in some cases. Diabetes and polycystic ovary syndrome also heighten vulnerability. Knowing these risks is vital for prevention and early detection. While risk factors set the stage, the pathobiology of endometrial cancer reveals how these risks transform into disease. Endometrial cancer's pathobiology blends hormonal and genetic forces. Normally, the endometrium thickens and sheds in cycles, yet unrelenting estrogen without progesterone can spark endometrial hyperplasia, a stepping stone to type 1 cancers. Here, mutations pile up, especially in the P10 tumor suppressor gene, driving early carcinogenesis. Type 2 cancers take a different route, often emerging from atrophic endometrium with rapid p53 mutations marking their aggressive nature. These distinct pathways, one hormone fueled, the other genetically erratic, shape detection and treatment innovations. Pathobiology shows how the disease unfolds, but the molecular basis uncovers the genetic gears turning beneath. Endometrial cancer's molecular roots hinge on distinct genetic shifts. Type 1 cancers often feature P10 inactivation, microsatellite instability, plus KRAS and beta-catenin mutations fueling their growth. Type 2 cancers lean on p53 mutations and HER2 overexpression for their aggression. The Cancer Genome Atlas refines this further, grouping them into 4 types: POL ultramutated, microsatellite instability hypermutated, copy number low, and copy number high. These molecular blueprints deepen our grasp and unlock doors to precise personalized therapies. Molecular insights guide therapy, but clinical manifestation reveals how endometrial cancer announces itself in patients. Endometrial cancer often signals its presence with abnormal uterine bleeding, the top symptom, especially striking post-menopausal women. Pelvic pain and odd vaginal discharge can follow as the disease progresses. In advanced cases, weight loss or trouble urinating emerge as tumors grow, yet early stages can stay silent with no symptoms at all, making routine checkups critical. Any bleeding after menopause demands swift investigation, as it might be the first whisper of this cancer, urging early action. Clinical signs alert us to the disease, but biomarkers and cytogenetic features offer a deep look into endometrial cancer's nature. Endometrial cancer's diagnosis and care lean on key biomarkers and cytogenetic clues. Serum markers like CA125 and HE4 often rise in late stages, signaling spread. Tissue markers include estrogen and progesterone, receptors P53 and P10, defining the tumor and shape treatment plans. Molecular markers such as microsatellite instability and pole mutations sort cancers into distinct subgroups. In type 2 cases, chromosomal instability stands out cytogenetically. These lab insights sharpen diagnoses, predict outcomes, and steer therapy decisions. Lab features refine our understanding, but metastasis shows how endometrial cancer travels beyond its origin. Endometrial cancer spreads to predictable spots like pelvic and para-aortic lymph nodes, ovaries, lungs, and liver. It moves through lymphatic channels, blood vessels, or direct extension to nearby tissues. Lymphatic spread often kicks off the process, making lymph node checks vital for staging. In later stages, hematogenous spread carries it to distant sites like the lungs and liver. Grasping these patterns guides staging, treatment, and monitoring. Metastatic patterns reveal the cancer's reach, leading us to staging for a full picture of its scope. Endometrial cancer staging uses the FIGO system to map its spread. Stage 1 keeps it locked in the uterus. Stage 2 sees it invade cervical stroma. Stage 3 marks local or regional growth, and Stage 4 flags distant metastasis. Precise staging shapes prognosis and treatment paths. Surgical staging with hysterectomy and lymph node checks stands as the gold standard, delivering the clearest view of disease extent. This detailed approach ensures treatment fits each patient's unique stage perfectly. Staging directs treatment, but screening and prevention aim to catch or stop endometrial cancer early. No routine screening exists for endometrial cancer in the general population. High-risk groups like those with Lynch syndrome may get transvaginal ultrasounds or endometrial biopsies. Prevention hinges on lifestyle. Keeping a healthy weight, staying active, and using hormonal contraceptives with progesterone can lower risk. For very high-risk women, prophylactic hysterectomy might be an option. Awareness of symptoms and risks is key. Prevention cuts risk, but when endometrial cancer strikes, therapy steps in to fight it. Endometrial cancer treatment begins with surgery, typically hysterectomy and ovary removal as the core approach. Radiation therapy helps in advanced or post-surgical cases. Chemotherapy targets high-risk or metastatic disease, while hormonal therapy fits certain types. Targeted therapies like immunotherapy hit specific molecular traits. Clinical trials explore new paths. Treatment depends on stage, grade, tumor features, and patient health. Therapy battles the disease, but prognosis tells us what outcomes patients might face. Endometrial cancer's prognosis varies widely. The 5-year survival rate hits about 81% thanks to frequent early detection. Stage at diagnosis drives outcomes, with early cases faring best. Tumor type and grade matter too. Type 2 cancers often signal worse odds. Molecular subtypes sharpen these predictions further. Age and overall health also sway survival. Close follow-up in the first years post-treatment is key to catch any recurrence early. Prognosis outlines survival odds, but current and future research pushes the boundaries for what's possible. Endometrial cancer research is advancing fast. Molecular profiling tailors personalized treatments to tumor traits. Immunotherapy shines in specific subtypes, boosting hope. Liquid biopsy alongside cytology from uterine fluid smears aims for early detection and tracking. Novel targeted therapies hit genetic quirks, while clinical trials test their power. Combination strategies blend these approaches for better results. Anamnesis or patient history refines these efforts. These leaps target earlier diagnoses, sharper treatments, and higher survival rates. Research fuels advances, but biblical integration brings compassion to endometrial cancer care. From a biblical perspective, our approach to endometrial cancer research and treatment can be guided by principles of compassion and healing. The Bible often speaks of Jesus' healing ministry, as in Matthew chapter 9, verse 35. And Jesus went throughout all the cities and villages, teaching in their synagogues and proclaiming the gospel of the kingdom and healing every disease and every affliction. This reminds us of the importance of holistic care, addressing not just physical but also emotional and spiritual needs of patients. Furthermore, Ethical considerations in cancer research and treatment can be informed by biblical principles of stewardship and respect for human life. Lastly, compassion drives healing forward.